Great. Okay. So we're going to talk about evidence synthesis to inform primary research. Thank you, Claire, for that introduction. I'm Professor of General Practice at Cardiff University, but actually also Director of two Health and Care Research Wales funded centres. One is the Evidence Centre itself, which is the main interest domain for this talk, but also Prime Centre Wales, which clearly utilises a lot of that thinking. How do we identify the relevant primary research, which is partly based on evidence synthesis work beforehand. So just a very brief outline. I'm going to comment about different review types and the different purposes of them. This is not a presentation about this is how to do systematic reviews, etc., but really talking about the why and the wherefore with them. But in particular, I'm going to be trying to compare systematic scoping and rapid reviews, because I think those are the three main types that underpin our identification of primary research, although there are several other review types as well, which may be suitable from time to time. So I'll mention those, and I'm going to give a couple of specific examples from the Health and Care Research Wales Evidence Centre work and how this evidence synthesis work programme links with the primary research. So first, just a little bit of sort of philosophical scene setting. One or two of you may be familiar with this poem by T.S. Eliot, in the middle of which, of the rock, it says, "Where is the knowledge we have lost in information?" And the following line is, "Where is the wisdom we have lost in knowledge?" Which is just reminding us ourselves about the purpose of standing back a little bit from all the information we have and trying to assimilate that into knowledge, and actually above that into wisdom, to make the right decisions about what we're going to do next in this area of research. And I'm going to just pose a brief question at the beginning. When we're thinking about designing our primary research, we think, okay, where does the library fit into this? Now, the concept of a library perhaps has changed over several years. It'd be interesting to know what your concepts of a library is as repositories of the evidence base for this purpose. But a very brief and arguably slightly facetious comment. This goes back to my earliest days in research, and I remember picking up a comment from a research registrar who was talking about researchers doing work that didn't need to be done. I don't think he was talking about mine, but he was talking about someone else's project, where essentially they'd found that somebody else was already doing their area of work, their question. And the comment was, researchers should be locked in the library for the first 3 months of their research. Be interested to know what you think about that from an equality, diversity, and inclusion perspective at the end. But this idea that we really, time spent locked in the library, in quotes, working out what is already known, i.e., from evidence synthesis, it's time well spent to be efficient and effective with what we're going to do next. I'm going to try and show you a more specific and up-to-date example about this. So this is right now, in fact, with one of our intercalated students in Cardiff University. So, and he was looking to do a project on artificial intelligence in healthcare. So where we started from through the summer was in the Health and Care Research Wales Evidence Centre. We had done a rapid review on the use of artificial intelligence in cancer diagnosis with our Public Health Wales colleagues. They've done this rapid review. I'll tell you a little bit more about some of the steps of the rapid review later on. And first of all, they selected 92 studies, and they identified that 52 of them had data about development and validation of artificial intelligence for diagnosis in cancer. And in fact, 28 of those centered upon breast, lung, and prostate cancer diagnosis. And they selected those in consultation with stakeholders to do an in-depth synthesis of those studies. And headline findings are that artificial intelligence does improve diagnostic accuracy in clinicians and radiologists with less experience of interpreting radiological images compared to their more experienced colleagues. So it can be helpful to aid and speed up cancer diagnosis, but actually still across the area of cancer diagnoses, a range of topics and different investigations in radiology, there's a need for further well-designed, high-quality research about that effectiveness of artificial intelligence. So sort of fair enough, nothing too earth-shattering there, but a need for further high-quality research. So at this point, we're having a discussion with our students saying, okay, well, maybe we could find some other areas of cancer diagnosis or other radiological investigations. The first ones have focused especially, for example, in lung on chest X-ray, but not other radiological investigations. Are there other areas that we could really dip into to undertake a further review in this area? So initially we thought, yes, there probably will be, and we suggested to the student that he should actually spend a bit of time on Prospero, which is the register of reviews in progress, to see what else is going on. And lo and behold, there's quite a lot going on in artificial intelligence in a whole range of aspects of healthcare. So other areas of urology, diagnosis and management, bone fractures, post-traumatic stress disorder, Alzheimer's, radiotherapy, max-fax radiology, drug addictions, food portion control, mental health in refugees, all sorts of things, clearly hugely heterogeneous. Then slightly more relevant to our interest that was starting to centre on other areas of cancer diagnosis. So there are reviews about AI in diagnosis and prognosis, oral cancer, thoracic disease, particular pathologies, and then a range of others, pharmacoepidemiology, plastic surgery, low back pain, and so on. So initially it was quite startling how much was going on in this area, and a little bit for the student disappointing that it did look like almost all further topics around either types of cancer or types of radiological investigations, someone was already at the table doing a review on artificial intelligence and whether it could aid diagnosis in those areas. So it was a little bit dispiriting, but ultimately still the same point, time well spent, because it means we don't have to replicate what somebody else is already doing. And we scratched our chin a little bit further and thought, well, okay, what areas are there that are still interesting and valuable potentially to do some reviews? And we centered on this one, the accuracy of artificial intelligence in detecting cardiovascular abnormalities from echocardiograms. And so that project has now started for the next 6 months, and we've engaged cardiologists to work with us and so forth. So yes, that basic point, it was time well spent in reviewing what's already out there, either genuine outputs already in the literature or work in progress from research registers. And now we're pretty confident that this is a domain that is not already overpopulated, and that's time well spent. So just a couple of comments. There are a huge number of types of evidence synthesis, of reviews. You see from the reference at the bottom, 14 review types at that point described in the literature, and these fairly well-known terms that we are familiar with: systematic review, rapid review, evidence maps, scoping review, realist, qualitative, etc. So I'm not going to go into those in great detail, except for the three that I've signalled earlier: systematic, rapid, and scoping. And as I say, I'm sure the slides will be circulated to colleagues today, and you'll be able to dig out that reference to look into a little bit more description and discussion about those different types of evidence synthesis elsewhere, if interesting and relevant for you. So there are a whole range of them. We're going to centre on a couple of them, 3, but just to think again to start with, why do we need these reviews? Well, I'm sure you are all familiar with the mountain of information that doesn't really need any further detail right now. But then we think, okay, particular purposes for it. Often there's actually a question which is looking to examine the consistency and the precision of findings in the medical literature, looking whether scientific findings are consistent, generalizable across populations or settings or treatment variations, whether they may vary by subgroups. So this often comes down to particular issues: the effectiveness of interventions, or the prevalence of conditions, or prognosis of conditions, or sometimes about diagnostic accuracy of tests. So in those particular cases, systematic reviews will almost certainly be the design of choice, if time and resources allow. But there is a certain industry, as I'm sure you're all aware, around those areas of systematic reviews. So we should, in Wales, digress briefly to mention and acknowledge the work of Archie Cochrane. So you may or may not be familiar, but Archie was the director of the MRC Epidemiology Unit in South Wales all those years back, which led to research about the prognosis in coal miners of pneumoconiosis and the exacerbating factors of smoking and so forth. And clearly his work was luminary back best part of 50 years ago, and led to the establishment of the Cochrane collaboration, which I'll mention in 1 second. But here's this time-honoured quote from him. Back then, he said, "It's surely a great criticism of our profession that we have not organised a critical summary by specialty and subspecialty, adapted periodically of all the relevant randomised controlled trials." So again, this focus on effectiveness of interventions at that point, and it led to the Cochrane collaboration, which actually has just celebrated its 30th anniversary at the annual meeting this year. So they are systematic reviews of primary research, human and healthcare and health policy, and internationally recognised as the highest standard for evidence-based healthcare. And sure, know the website, and the classic example that kicked it all off was the review about prenatal steroids for premature babies and substantial lowering of mortality rates. So all the details are at the Cochrane Handbook. It is a great website, and it will bring you up all the methods that are required. But just to mention in passing as well, so Cochrane is health and healthcare, etc. There are others, principally Campbell collaboration, which examines social interventions and maybe in the fields of education, crime, justice, social welfare, or international development, for example. And organisations like the Joanna Briggs Institute feed particularly into the Campbell collaboration work. So there's a whole industry around systematic reviews and the effectiveness of interventions. And just briefly, just to note at this point in passing, that the stages of a systematic review, I'm guessing everyone's very familiar with these works. I'm not going to dwell in any detail, but it is basically the same as same outline in principle as any other research. The IMRAD structure, aims and objectives, introduction, methods, results, discussion, etc. And so for a systematic review, the methods are going to identify the search strategy, what definitions we're examining, the inclusion-exclusion criteria leading into a data extraction method and template usually, and a plan for analysis. It often starts with a thematic analysis and may then lead into a meta-analysis if there are sufficient homogeneous, well-designed trials. And considering the quality of the evidence, the risk of bias of the published studies, a funnel plot to assess publication bias in the literature available, and we may undertake sensitivity analysis, for example, only examining the best quality evidence or particular subgroups that ideally are specified upfront, a priori, and make sense to us in this particular question. So, for example, in that one that I mentioned about echocardiograms that we're going to look at, we might take a split between transesophageal echocardiograms and transthoracic echocardiograms. They're different. Does artificial intelligence have different accuracy in those different groups? So that would be subgroups, and then we would present results, typically with a Prisma flowchart of the selection of studies, and then a narrative overview, and sometimes quantitative analysis, meta-analysis, etc., if the literature and the data justify it. And then a standard discussion section structure, principal findings, strengths and limitations, context, implications, further research, and so on. So just reminding ourselves about the outline of systematic review stages. And they were particularly applied usually to effectiveness, prevalence, prognosis, or diagnostic accuracy. But we go on a little bit further and we think, okay, why do we need these reviews? Well, a key area that we are interested in is to inform the research agenda. That could be more widely, or it could be for our own next research. We can use a review to identify, justify, refine hypotheses, maybe estimate sample sizes that are required for primary research, or to examine further adverse effects or covariates that require further study. Now, that can be designing our own research, but I think a particular digression that might be of relevance to all of us here is it's all about grant applications as well, actually. Now, the typical headings that a grant body will ask for in a proposal for research are these. What is the problem being addressed? Why is the research important for health or well-being? A review of the existing evidence. How does that review support this proposal? And then leading into question, aims, objectives, a plan, who are the team, what are the costs, PPI involvement, etc. So clearly I've highlighted the one in the middle there, which is directly a review of existing evidence and how that supports this proposal. But in fact, the first two are also highly informed by a thorough review of the literature. So we are, in this case, identifying our own research agenda, and others may also have a wider interest in what the research has to offer for their field, for their agenda, but it's particularly relevant to grant applications. And alongside the research agenda is also informing decision-making, particularly for policymakers who may be using reviews to inform guidelines or indeed legislation about treatment, intervention, routine practice. And we will all be well familiar, I'm sure, so NICE comes in here with its usually systematic reviews, but policy colleagues, I'm going to say some more in a moment, often more interested in the scoping or the rapid reviews. And delivery, those involved, responsible for delivery in the NHS or social care, they might actually be more interested in a different type of review, like a realist review. What works for whom, in which circumstances, etc. So going to just take a little bit of time to talk about scoping, rapid and systematic reviews. Again, so what is a scoping review? So again, references at the bottom, you can dig those out later. The definition is to determine the scope or coverage of a body of literature on a given topic, to identify the volume of literature and studies available, and an overview, could be broad or detailed, of its focus. So what does that actually mean? Okay, this might be some more helpful bullet points. To identify the types of available evidence in a given field, maybe to clarify definitions, to examine how research has been done, the methods in a topic or field, to identify characteristics or factors relating to that, could actually be a precursor to a systematic review, and in particular to identify knowledge gaps from scoping the literature to date. So we might be faced with the question, should we best do a systematic or a scoping review? So we start, if you like, with the baseline of a systematic review, but which may then be adapted to a scoping or a rapid review. Systematic review is to identify and retrieve evidence that is relevant to a particular question or questions, usually focused, as we said earlier, around effectiveness, prognosis, diagnosis, etc. And the evidence will typically be critically appraised and provided in a synthesized account in a structured way. And it probably will draw on a relatively narrow range of quality assessed studies. And it will include implications for practice out of that narrower selection and presentation of studies. A scoping review is a bit different. It is perhaps more to provide an overview or a map of the available evidence. As mentioned there, it may inform a systematic review, probably typically with a broader range of studies, but less likely to assess the quality. Will be giving equal value to different traditions, not privileging particular types, so qualitative and quantitative, for example, may be given more or less equal weighting in these types of scoping reviews. But clearly the nature of that evidence is that all we can provide is a narrative or descriptive account, probably less likely to be examining methodological limitations or risk of bias in those studies. And it may be slightly less suitable to guide practice, particularly perhaps policy. So a little head-to-head between systematic and scoping. Now, rapid reviews are a form of knowledge synthesis that follow the systematic review process. That's the key here. They're really much more in tune with the systematic reviews, but components of the process are simplified or omitted to produce information in a timely manner. Again, this timely element is key to rapid reviews. So quite often they might be done in a matter of weeks. Still with a fairly narrow question, probably structured around the PICO format, population intervention, comparisons, outcomes. The searches, because of the limited time, are more limited, but still nevertheless transparent or explicit and reproducible, therefore. And selection is still based on inclusion and exclusion criteria. We need to know what we're looking for and whether it's relevant. Appraisal of those studies is going to be more time limited, but can still be critical and rigorous. And there may be a descriptive summary of those data. It may be quantitative, but it may be more likely an overview and a descriptive summary. So a couple more comments. When and who for? So policymakers typically require valid, reliable evidence to support time-sensitive decisions. That's what's driving it here. And they're likely to accept an adaptation in the quality or efficiency of that evidence review process to get that time-sensitive evidence available. And they want it in a format that's actionable and relevant to strengthen their health policy or systems guidance. The scientific community might also be interested in rapid reviews of the available evidence, using usual methodological approaches to try and understand, where are we with this research? What are the gaps? What's the future research that's required? At that point, it's starting to morph a little bit more into the scoping review. But to say policymakers clearly often want what you might call the slimmed down systematic review in a rapid period of time to help them develop their policy guidance. So going to try and put some flesh on the bones there, give some examples from what we are doing in the Health and Care Research Wales Evidence Centre, funded, clearly, there's a clue in the name, by Health and Care Research Wales on behalf of Welsh Government. And it is to certainly want to pay compliments and acknowledgements to my colleagues, Alison Cooper and Natalie Joseph Williams in Cardiff and Ruth Lewis in Bangor University, who are my associate directors for this evidence centre. So it was launched in March of this year, and at the launch event, the Health Minister said this evidence centre is essential to the future of health and social care in Wales. Looking forward to seeing all the incredible things the centre achieves. So we thought, well, no pressure then, we'd better get on with that as soon as possible. So this is our business, conducting relevant, rapid, responsive and rigorous evaluations that will be readily available to inform evidence-based decision-making in government, NHS and social care in Wales. As you see, a clue there, it's often about rapid reviews, and they're readily available in a time-sensitive way to inform that decision-making by policymakers across those domains. So just a little bit about who we are, as well as ourselves in the core centre across Cardiff and Bangor universities. We also work with partner groups who are particularly expert in undertaking these reviews, often rapid reviews, sometimes systematic reviews, etc. So we have a Cardiff group, which itself is a combination of the SURE team, Specialist Unit for Review Evidence, and the Joanna Briggs team from Healthcare Sciences, the Wales Centre for Evidence-Based Care. So that's one group in Cardiff. There's a second group in Bangor University, which includes particularly the health economics colleagues at CHEAM, the centre there. Also Public Health Wales Evidence Service, so that's in the NHS. They have an evidence service that's relevant to this domain, so we work very closely with them. Also Health Technology Wales, also in the NHS, therefore, and HTW sometimes refer to themselves as the Welsh NICE, so that gives us a clue about their areas of interest. And also, as I will explain in a moment, colleagues at Population Data Science at Swansea University, which is the part of the primary research work that we do, but the others are all engaged in evidence synthesis. So really the point from this slide is the three work programs on the left. We've got the groups, got the core team, got the partners, and we engage in these 3 work programs. Firstly, about the science policy practice interface, working with policymakers to identify what their evidence needs are and how urgent and how important they are. And I'll say some more in one moment about that. Then the evidence synthesis work program and the rapid evaluation and primary research work that goes with it. And the key, the relevance to this talk today, is how evidence synthesis informs some of that primary research. And all our work all along is underpinned by public involvement, knowledge mobilisation and impact activities. So first of all, the science policy practice interface work with the stakeholders in policy and NHS and social care Wales, etc. It's about establishing a relevant work programme that addresses the most important policy and practice needs and which is most likely to achieve change in our services. And we engage with stakeholders from policy, from practice, from academia, all throughout the research process to identify these questions for our work programme. So, for example, in the latest round of consultations, we've engaged with a whole range of policy leads across Welsh Government, 28 meetings with them, and also other evidence services in Welsh Government. There's one called Science Evidence Advice, and also Knowledge Analytical Services. We engage with them to make sure that nobody's competing or duplicating with each other, and that different groups will do the things which are most suitable to their expertise. But as it says there, it's identified a lot of questions from these various stakeholders that could be important, and then we need to assess how important are they, what's the burden that is going to be tackling, what's the cost, how much, where's the pathway to impact, how much difference will it make, how and by when. We assess all these proposals, similarly, all in the mix as well, 10 from NHS leads and also a further 6 from social care leads. So we identify the various questions. That's not so much the focus of today's talk, but I'm very happy to provide more information about that for those interested. But we then put the selected topics into our evidence synthesis programme and ensure the objective is timely evidence reviews to inform policy and practice. We work with our own research teams and with the stakeholders throughout in a collaborative way, and typically the product is about rapid evidence reviews, usually in 2 to 3 months. Not the longer version of a systematic review, but nevertheless the methods are more aligned with the systematic review approach, and there is quality assurance to minimise the bias and errors. So that's our stock in trade, but when suitable we will also do a systematic review or others. So evidence synthesis programmes, just a few examples. Only this one slide. So one that was recently completed was a question about what is the forecasted prevalence and incidence of chronic and long-term conditions in Wales. So all the regular big long-term conditions, whether it's diabetes, respiratory, heart disease, mental health, you name it. We wanted to know what is the forecast for 10 years' time for prevalence and incidence, which was to inform a Welsh Government paper which was forward-looking for the NHS in 10 years' time to be able to start planning service provision. What will it look like? What will it need to look like for 10 years' time? So that paper has now been produced, in fact, with the Science Evidence Advice team using our evidence, and has been fed up to Welsh Cabinet to make decisions about, again, shifting priorities in the NHS over these next 10 years. Second one, I've mentioned already, this one about effectiveness of artificial intelligence in radiological diagnostic investigations. So it came from the Health Sciences Directorate, and they wanted to inform a national diagnostic programme and strategy. And that review has been recently completed. Another one that's just coming to an end right now was about the public health risks associated with so-called special procedures, which means tattoos, acupunctures, body piercing, electrolysis, cosmetic dermal fillers, and some others. And the Special Procedures Group of Welsh Government are looking to update the Public Health Wales Act with information about harms and further risks that might be involved, and therefore also guidelines for quality of provision of services such as those. So that was a rapid review that's just been completed. And one more is about the safe interval for optometry review intervals. if and when you go to an optometrist, is an annual review the obvious interval at which to be reviewed? What's the evidence for that? Could it be longer? Should it be shorter? Does that depend on who you are, i.e. with which other conditions you may have? So that was the nature of the question, and it's being used by the optometry services, the chief optometry officer for Welsh Government, to revise the strategy and to revise recall intervals in optometry. Over the next year, they'll be giving guidance. So going to keep that one in our minds as we come to the primary research in a moment. So the primary research programme, just briefly, population data science studies. I mentioned the SAIL Databank colleagues at Swansea. We have access to that. We have resource in the SAIL Databank to be able to analyse data sets to answer some of our questions. Economic evaluations is a particular area of importance for us as well. So we work with those colleagues in Bangor University for that area of work. And we may also undertake some in-house studies, probably on a smaller scale, qualitative evaluations, etc. So again, the examples in the primary research programme, we are looking at the cost impact of patients with chronic pain on primary and secondary healthcare services in Wales. It's come from pain service directors who want to know what the impact is. We're working with the SAIL data science team to identify the relevant data and to be able to make that cost impact assessment. More in-house qualitative work, the second one there, we're looking at patients' needs and preferences for emergency NHS dental care. What could the emergency dental care service look like, which is to identify dental reform strategies led by the Chief Dental Officer in the near future. A similar one comes from the Chief Pharmaceutical Officer for Welsh Government, and there are proposals perhaps to roll out a programme which is currently available only in Hywel Dda Health Board, in which people with celiac disease, rather than having prescriptions for gluten-free products, actually are given a credit card with the same amount of cash on it, and they can choose how to spend it on whatever they want in a grocery store, and to examine whether that service is actually better valued, provides more benefits, or does it lead to disbenefits and any disadvantages for particular groups among people with celiac disease. So we're undertaking a qualitative evaluation piece of work in relation to that and the economic impacts that has for people with celiac disease. And the last one, which is more relevant right now, which is this link from evidence synthesis to primary research. Back to optometry and examining the minimum interval at which patients should be recalled for their eye examinations. So out of the review, which I'll show you in 1 second, identified some further research needs, and could we take that forward with some primary research? So I'm hoping you are still awake just for a few more seconds, and then we'll open up to discussion. So this was the review that we published, the rapid review about prognostic factors for changes in eye health or vision. And very briefly, the results, there were 19 studies, and it identified various factors such as age, sex, ethnicity, intraocular pressures, family history, etc., which are potential prognostic factors for a change in ocular health or vision. But quite typically, there was really quite a low evidence base, 1 study per outcome, sometimes a low number of studies per outcome, and often quite specific populations, not generalizable. And we did identify research gaps from it. These prognostic factors need to be investigated more for their effects on ocular status, particular absence of evidence in relation to adults under 40, and actually particularly for UK-based evidence. So more primary research is needed. And so, of course, yes, we're in a position now to talk with the SAIL Databank, identify what data they've got to examine those questions more particularly in a primary research approach, building on the evidence synthesis that we have actually just done to answer those questions about evidence-based minimum recall intervals. So that's an example of what we're doing at the moment in the Health and Care Research Wales Evidence Centre. Just to say very briefly, this Health and Care Evidence Centre came out of the COVID Evidence Centre from the previous couple of years, and during which we also had this link as an evidence centre to examine COVID-related topics, all sorts, public health, effectiveness of treatments, impacts of the non-pharmaceutical interventions, etc., and could also lead that forward into primary research where indicated. So, for example, out of some of our work on long COVID, from reviews, we were able to take that forward, commissioning some primary research. And just a very brief point, you're probably aware that there were numerous evidence centres across the numerous countries addressing the COVID challenges over the last 2 or 3 years. And to our knowledge, our evidence centre is the only one that has actually made this link from evidence synthesis to primary research. The others are all only doing evidence synthesis and then contributing that to policy and healthcare decision making, fair enough. But this connection to primary research was actually a unique feature for the Wales COVID Evidence Centre. Anyhow, more information about the current Health and Care Research Wales Evidence Centre on our website. You're welcome, and there's obviously a contact point. You can contact me as well, or our colleagues to explore particular questions. We welcome that discussion. I think I've probably said enough to you now, so we'll open up to questions and comments and discussion points.